Good morning and afternoon to everyone. I am Patrick Neff, PGY3 resident, doing the Journal Club today. This will be my last Journal Club presentation of residency, so it's quite exciting. And this trial is quite exciting. It's the ISAR-React 5 trial, which studied Relinta versus Effient, just for lack of confusion, which will be a lot more explained more clearly here in the other slides, but in patients with acute coronary syndrome. So as far as dual antiplatelet therapy in combination with aspirin, previously, Plavix was kind of the mainstay, aspirin and Plavix for 12 months. But as newer therapies have come out, as far as the P2Y12 class, they have started to expand their investigations as far as using these in place of Plavix. But there had never been previously a head-to-head study. They had tried to do it, but they couldn't meet their enrollment numbers, and so it was aborted. And so no real good data head-to-head wise, but that's is what the ISAR-React is going to look at. Just a little bit of an outline, how our discussion is going to be geared today. We're going to do just a little bit of background about the study, its purpose, kind of why it was important, and some of the other medications used previously, and current recommendations from both the American and European societies of cardiology. Our next step will be just look at how the overall trial was designed, and then we'll kind of get into the methods and then some of the results and conclusions, and then how do we interpret these results and whether or not the study was good. And if we can use these same principles kind of in our practice, we can adapt what this study showed and use it in current therapy. Just some of the background. So obviously antiplatelet strategy is a large area of interest in cardiovascular medicine as far as ACS, stroke and TIA, and PAD. There's been tons of studies that look at which regimens are the best as far as combination therapy, monotherapy, even triple therapy in some instances as far as anticoagulation on top of dual antiplatelet therapy, how long people should be on these types of therapies, when to hold them, when to stop them, such as if they have any kind of invasive procedure planned, et cetera. And just, is there a clear benefit in keeping people on these long-term therapies with the associated increased risk of bleeding? And so they have looked into that quite a bit just because of the risk of intracranial bleeding and GI bleeding. So they want to make sure that, obviously, if we're putting people at lifetime risk of these events, we want them to get the best bang for their buck as far as their antiplatelet properties and keeping their stents open as well as their arteries. As far as previous regimens, obviously aspirin has been pretty established as a key part of the treatment for ACS, which is kind of what this talk's going to focus on, is ACS and not the stroke, TIA, or PAD. But so aspirin has showed earlier benefit in patients at risk of occlusive vascular events in a study of over 200,000 patients. And so that's been kind of the mainstay. It was the anti-thrombotic trials collaboration that kind of showed this. It was a loading dose of 162 to 325 milligrams, and that was recommended in both STEMI and in-STEMI patients, irregardless of the plan for PCI. So irregardless of plan for invasive evaluation, or if they had planned on putting any kind of stents in, or if they plan on doing any kind of CABG, irregardless, aspirin is recommended as loading dose initially. And then following treatment, as far as whether or not that is with PCI or CABG, or if they just opt to do a conservative therapy maintenance dose of 81. It's kind of what we do here in America, but it was studied at 75 to 100 and no more than 100 milligrams daily for secondary prevention indefinitely. And so that's kind of why we keep everyone on aspirin 81 milligrams daily, is based largely in part on the results of that previous investigation. Okay, so obviously we have aspirin as kind of the core backbone of our dual antiplatelet therapy. And as far as the treatment for ACS, in the CURE trial, it was a study of over 12,000 patients that looked at the benefit of dual antiplatelet therapy and in-STEMI as far as aspirin on top of a P2Y12 inhibitor. Previously, it was, as I was saying earlier, it's been kind of aspirin Plavix in the past just because of the extent of Plavix being studied and the significant improvement, or I guess decrease, in subsequent occlusive vascular events while on this therapy. And so kind of the mainstay right now is to keep patients on this dual antiplatelet therapy for a total of 12 months after their ACS event, if they get any kind of PCI done. And so that's kind of what I'm going to focus this talk on, is patients who have kind of had ACS, have undergone invasive evaluation of their anatomy, and have had stents placed or are undergoing CABG. So as far as previous recommendations for STEMI, if they're going to get any kind of lytics and they're not planning on doing stenting, so for the outlying facilities and those kind of patients, it's still Plavix is currently kind of the recommendation from the ACC and the European societies in combination with aspirin. So based on the TREAT trial, it looked at Plavix and Brilinta getting each of those therapies after lytic therapy, if they got Brilinta or if they got Plavix in combination with aspirin. There was no difference in the efficacy of these at 1 year, and they did have some concerns about the increased bleeding on Brilinta, and so that is why Plavix is still kind of recommended as the first line in these patients after lytic therapy. They did, however, do a meta-analysis of the TREAT and Plato trials and kind of combined all this information and all this data and kind of extracted it, and they did show a 13% reduction in relative risk in death, stroke, or MI in patients who got Brilinta. And so they said that they can be used, but obviously Plavix is still their first recommendation. But just know that has since kind of changed recently based on that meta-analysis that it is okay to use Brilinta now. And as far as STEMI, if they're going to undergo PCI, obviously Brilinta or Effient is currently recommended over Plavix. And we'll kind of get into why that is, just based on previous studies and the success of those two medications in their respective investigations. Okay, all right, that's perfect. Sorry about that. So obviously moving on over from STEMI to NSTEMI. So NSTEMI with PCI, currently it's Brilinta or Effient recommended, with everyone kind of leaning over on the Brilinta side and away from Effient currently. And that is because of the Triton-TIMI trial, which looked at Effient versus Plavix in high-risk patients undergoing PCI. Didn't show a whole lot of success in the NSTEMI as far as those who underwent PCI. And so that's why people kind of shy away from Effient. And again, and the earlier Plato trial, it was Plavix up against Brilinta and ACS. And there was significant benefit in Brilinta over the Plavix. And so that's why it's kind of recommended now over Plavix mainstay for NSTEMI in patients who have NSTEMI undergoing PCI. Obviously, each of those two trials have some pretty significant limitations. I won't get a whole lot into that right now, but just know that kind of everyone kind of takes those with just kind of a grain of salt, that obviously there isn't a whole lot of difference as far as the efficacy of these two over Plavix, but if everyone kind of had their pick, everyone is still kind of shying away from the Effient up until this trial. And as far as conservative management for the NSTEMI, so those patients who have NSTEMI undergo invasive evaluation, but do not undergo PCI or have stents placed, Brilinta is kind of recommended as the second antiplatelet agent in combination with aspirin for a year. And that is just based on the review of the previous Plato trial I was kind of talking about earlier, just that there was significant improvement or I guess like a decrease in the number of occlusive vascular events in the patients on Brilinta as opposed to Plavix. Effient did not show that same efficacy over Plavix, and there were some concerns about bleeding. So again, that's why Effient is kind of a second line almost, second to Brilinta now in current practice. So this is kind of where we get into this study, ISAR-React. This is kind of a choose your fighter based on a previous movie. It's The Karate Kid for those who don't know. So our main character, we will say, is Johnny, which some would say he's the villain, but he's Brilinta in this story. He's stronger. He had the victory in the Plato trial, and he is often preferred because of how he's dosed. He's given as soon as ACS is diagnosed. There isn't a delay in therapy, which, with Effient, as we're going to talk about later, it's not given until after you have shot dye into the coronaries and they have a defined anatomy, at that point you start to host the FVN. And so that's kind of one of the stigmas around FVN, is that, you know, people don't like to wait to give it. If you're going to treat an ACS, people say, you know, if it's diagnosed, it should be treated immediately with dual antiplatelet therapy. Previously, aspirin Plavix has segued into aspirin and Brilinta. But then, you know, kind of FVN, you have to wait until you shoot dye, and that could be the next day, it could be over a weekend. And so people kind of were hesitant about keeping people off of dual antiplatelet therapy for that long. And then there was some previous concerns with the bleeding risk in Effient. And so that's why it's represented by our main hero, in some people's opinion, as young Danielson. And so that's what was the ultimate goal of the ISAR-React 5 trial. You know, everyone kind of talks about Brilinta being the superior drug, but is it really superior to FVN in patients with acute, you know, who have ACS, who will be undergoing invasive coronary evaluation? So this study focused on patients with ACS who are undergoing left heart catheterization. And is Brilinta superior to Effient, or is Johnny going to crush Daniel in the tournament final and put an end to the ruthless torment that began when Daniel moved into his town? So here's these two medications, obviously some pictures of them. On the left, Brilinta here, its loading dose is 180 milligrams. And again, that's given pre-angiography. The Atlantic trial previously kind of looked at, you know, should this drug be given in the ambulance versus in the cath lab? Is there a difference in timing of the administration? There was no significant difference, but it's just given pre-angiography. And then its maintenance dose is given 12 hours post-loading dose, or PCI. And it's 90 milligrams twice daily. And it is continued for 12 months, you know, in combination with the daily aspirin. On the right here, we have Effient. Its loading dose is 60 milligrams. But how it's given, obviously, is just a little bit different. Earlier, I kind of alluded to it. For STEMI, as soon as it's diagnosed, Effient is given at its full loading dose in combination with full dose aspirin. But for NSTEMI, you only give the Effient after angiography is done, if they're going to give PCI, or if PCI is planned or done. And so once you shoot the dye, it's given, and then, you know, obviously they put it in the stents after that. So, but it's not given pre-angiography, so that's the important part about this. And then its maintenance dose is given on the first day following the procedure, and it is once daily, 10 milligrams. But if you're less than 60 kilograms or over 75 years old, in some studies how it was done, it's 5 milligrams. There wasn't a whole lot of reduction in the efficacy of the medication, and didn't, so it's okay at the 5 milligrams, but obviously it's preferred at 10. But if there's limitations to that, then it's okay to do 5 and have similar efficacy. And again, it's continued for 12 months with the aspirin as well. Some of the concerns, obviously, with each of the medications is bleedings. On the Brilinta side, most notably, history of intracranial hemorrhage is a pretty significant one. Should not be given to these patients. And then on Effient, any history of TIA or stroke, regardless of whether it was a hemorrhage or ischemic, you should not give it to these patients. Then here's a little chart comparing all 3 medications, Plavix, and then Effient in the middle, and on the far right is Brilinta. And so obviously some of the comparisons here. What I thought was interesting, as far as the onset of action, in Plavix, it's slowed, and then obviously it's rapid in each of the other 2 medications, which is kind of why they've been kind of the mainstay of all the recent, I guess, like the investigations and studies as far as these 2 medications over Plavix. And that's what it's kind of, Plavix is kind of on its way out in some areas and in some people's minds.
Neff keeps breaking the computer. I apologize. Where are we going? just the first one after that. Okay.
Okay, so trial design. It was put on by a center in Germany, which is kind of a big area or institution as far as invasive cardiology. And so things are kind of accelerated over on the European side of things. So they do a lot of the studies as far as the forefront of therapies for ACS. It was multi-center, randomized, open label. They enrolled 4,018 patients based on the power they needed. They said they had a goal of about 4,000. I just got just a little bit over that. Its primary endpoint was death, MI, or stroke at 1 year. And then its secondary endpoints, the first one was kind of the big one. It's the safety endpoint, and that is type 3, 4, or 5 bleeding on the Bark scale. And then obviously the other secondary endpoints, all-cause mortality, stroke, MI, and then in-stent thrombosis. So how to be enrolled into the trial? You had to have you had to be hospitalized for ACS. That's either STEMI, in-STEMI, or unstable angina, and they had to have plans for invasive evaluation, so plans for left heart catheterization. Pretty extensive exclusion criteria, obviously intolerance of or an allergy to either of the medications, history of any kind of stroke, TIA, or intracranial bleeding. If they had a known intracranial AVM, aneurysm, or any kind of cancer, active bleeding, or clinical findings suggestive of high risk of bleeding. If they had gotten previous lytics within 24 hours or 48 hours based on what kind of lytic therapy, if their platelets were under 100, if they were anemic below 10, if they had an INR over 1.5, ESRD, advanced liver disease, and then obviously, if they have something else going on that they're not expected to live past 1 year, these patients obviously wouldn't be included in the study either. And then kind of look over those, but not too outrageous. And so how it was done, so they had 4,018 people randomized. As far as a Berlinta group over here on the left, they ended up assigning 2012. In the Effian group here on the right, it was 2006. As I was saying earlier, each of the drugs loading dose was given in accordance with how the medication is given in practice. And so on the Berlinta side of things, it was given as soon as they were diagnosed and put into the Berlinta group. But for the Effiant side of things, they did not receive the medication until after they had shot dye into the coronaries and defined the anatomy. But it was prior to them putting any kind of stents in. And so some of the baseline characteristics that I thought were just kind of interesting and important to note. All the patients obviously have pretty significant cardiac risk factors. It's pretty evenly divided between each of the two groups. As far as the history, any kind of like cardiovascular history, especially as far as heart disease, previous MI, previous PCI, and then CABG were pretty similar in the two groups. But as far as what they came in with, as far as what their ACS was, each of the groups pretty similar. As far as if it was unstable angina, STEMI, or STEMI, and so not a whole lot of difference between each of the groups. It was pretty well, I think, overall balanced. So I thought that was a good thing about the integrity of the study itself. I broke it again. All righty. So 84.1% of the patients ended up actually undergoing PCI, and then only 2.1% underwent cabbage. Of the patients who underwent PCI, 12.3 of that 84.1% did not receive AP2Y12 as their second antiplatelet. They received something else, and that was just based on who was doing the, I guess, like stenting and just like their personal preference, and if there was, I guess, any kind of contraindication to receiving those two therapies that was not previously identified. As far as the PCI and the NSTEMI patients, in the Berlinta group, they were loaded on average about 6 minutes after they were put into that group, and 98.7% of the patients actually received the load. However, in the Effient group, each of these patients were, on average, didn't receive their load until about 61 minutes after randomization, which again, you know, they have to be taken to the cath lab, have to have dye shot, and then they have to have the medication given. And then after it's given, at that point, stenting is done. And so of this group, only 86.1 of those patients received the actual load, which is a pretty significant difference from the other group, which is almost 100% of those patients getting loaded. At discharge, in the Berlinta group, 81.1% of the patients had received the trial drug. In the Effient group, only 80.7% of the patients had received the trial drug. So pretty similar there, but obviously significant differences in the groups, or in the rate of who was loaded and who was not, but we'll get it into more of that later. Here's some of the results. So obviously just based on how the graphs look, and the colors and stuff, you don't have to be super intelligent to know that there is a pretty significant difference between those two. But as far as the numbers and stuff, it did show that it was actually Effient, it was superior. As far as a primary endpoint event, in the Berlinta group, it was 9.1% of patients, or 184 of those 2012s, who were put into that group at the beginning. In the Effient group, 6.8%, or 137 of the 2006 patients in that group had an endpoint event. And then as far as the composite of death from MI, stroke, or any kind of cardiovascular cause to include ACS, 8.1% in the Berlinta group, and 6.3% in the Effient group. So pretty significant difference there as well. So obviously just based, you know, on these numbers, it would appear that Effient, you know, obviously they had a lot fewer of the events, such as ACS, MI, or stroke. And then they had fewer deaths as opposed to the other patients who received Berlinta. And then just kind of a breakdown of some of these secondary endpoints. As far as MI, over here on the right is kind of an explanation of what the type 1, 2, 4A, and 4AB, and 5 MI means. So obviously type 1 is spontaneous infarction. Type 2 would be like your type 2 in sepsis and stuff, just an ischemic imbalance. So in patients who probably have known CAD that is obstructive, but just has not caused a significant clinical event as far as heart health, but have elevated heart enzymes, you know, in the event of like hypotension or sepsis or something else. So then type 4A and 4B. 4A is any kind of infarction related to PCI. Type 4B is infarction secondary to an in-stent thrombosis. And then in type 5, it's infarction secondary to cabbage. And then STEMI, obviously, okay, so on the right here is the Effient group, I apologize. And then on the left is Berlinta, and it's a pretty significant difference in the amount of STEMI patients in the Berlinta groups, 31 compared to 14 in the Effient group. And then obviously just MI and type 1 MI is probably, like, I'd say is the most notable as far as the NSTEMI, but it was significantly higher in the Berlinta group as opposed to Effient, which kind of goes back to our initial results as far as primary endpoint. Effient having a lot more success as far as helping patients out who have since done, and them not having future events. So a lot fewer future events in the Effient group. And then as far as our safety endpoint, again, it was BARC 3, 4, or 5 bleeding, which is kind of here on, it's defined here on this table over on the right. So 3A is overt bleeding with hemoglobin drop of 3 to 5 grams per deciliter or any transfusion. 3B is overt bleeding with hemoglobin drop of greater than or equal to 5 grams. And then if they had to be on any kind of like vasopressors, or if the bleeding is secondary to surgical intervention or tamponade. Class 3C is intraocular or intracranial bleeding. Class 4 is bleeding related to CABG if they have to get over high units of blood, or if the chest tube output is significant over a day. And then 5 is fatal bleeding, which is kind of interesting. So as far as a Brilinta group, high 0.4% of them, had increased risk of bleeding or an event as far as a safety endpoint. So they had evidence of 3A, 3B, 4, or C bleeding, or 5 bleeding. What's interesting in the Brilinta group is they have had a total of 4 cases of what they said was class 5 bleeding. One of those, they said it wasn't 100%. They didn't know 100% if it was fatal, but it was most likely fatal based on how it was, I guess, presented to them. So I just went ahead and included that in fatal bleeding because it sounded like it was fatal bleeding. They just couldn't 100% confirm it. But as far as all the numbers and stuff, it was included in this as far as the stats being run. In the Effiant group, they only had a safety endpoint event in 4.8% of the patients. And so not a whole lot higher bleeding in the group who received Brilinta, but not significant overall. And then here's just kind of a chart of the results further. So obviously significant improvement in the group who got the Effiant, a lot safer as far as them having future events, and not at the expense of increased risk of bleeding. So obviously as far as our overall results, the composite endpoint of death, MI, or stroke was significantly lower among patients who received Effiant than among those who received Brilinta, or in other words, our villain Daniel completes his checklist of destruction on Johnny's life. He stole his girl, ruined his Halloween dance, and then won a tournament that our friend Johnny was supposed to win. And so obviously Effiant it was kind of put into this trial to show that it was inferior, and that, obviously it shouldn't be used a whole lot, but it ended up coming out on top, and it showed that it was actually more efficacious and did not have associated increased risk of bleeding despite that increased efficacy. So as far as after the trial was done, pretty significant rate of patients stopping the drug in the group are 15.2%, as opposed to 12.5% in the Effiant group. Some of the reasons for people, it could have been the cost, it could have been it being dosed twice daily. Shortness of breath is kind of a significant side effect. And so there was some concern that possibly that had led to it being stopped, but it seemed like a lot of the time it was either the cost or the fact that it was, being taken twice a day, that these patients were switched over to Plavix once they left the hospital. And so, obviously there's some concerns about whether or not all these patients who stopped it could have affected the trial. We'll see if that did have impact on Brilinta. And so that kind of leads into our bonus question about the stats. And that is what biases could have been introduced in the study if analyses had been done on a per protocol instead of an intention to treat, given the significant rate of people who stopped under the arms. So as far as breaking this down, over here on the left, so all patients in a treatment group are included in the analysis, irregardless of what treatment they received. So if an investigative treatment group has 100 patients and 30 patients in that group die total, irregardless of whether or not they got treatment, they're still included. So then the risk of death of the investigative treatment is 30 over 100 or 30%. And then in a control group, the risk of death is also 30. And so as far as the relative risk, it'd be 1% because 30 over 30. And then as far as relative risk is reduced, it'd be 0% because there is no difference in the relative risk, as opposed to, or there is no, I guess, it shows no true benefit from the investigative treatment. But on the per protocol side, if you use this, they are able to go back in at the end, and patients who did not qualify for treatment or didn't receive it are removed from analyzing the effect of that treatment. So using a similar example, if the investigative treatment group has 100 patients and 30 patients in the group die total, but only 85% of the 100 actually received the treatment because 15 of the 30 total deaths were, I guess, prior to receiving the treatment, then the risk of death of the treatment equation becomes 15 over 85 because they're allowed to go in and take out the 15 patients that died. And so then it's not 100, it's 85. And then if 15 died prior to receiving the treatment, then only 15 would have died after receiving the treatment. So the risk of death of that treatment is 18%, and that comes from the 15 over 85. If the control group risk of death is 30%, then as far as a relative risk, it would be 18% over 30%, which is equal to 0.59 or 59% relative risk, which would show, if you looked at these numbers, you could have a perceived 41% benefit from this new investigative treatment. Whereas if you do it on the other side, there is no true benefit, but just based on having those people taken out of the stats at the end, it shows a false benefit from the new treatment. And so if they had done this similarly in our trial, then it could have potentially shown, I guess, a significant benefit in Brilinta, but since it was done over here on the left, intention to treat, it did not. So here's some more references.
And so I think, so God bless the cardiologists, man. We love cardiologists. They're like the original, like UFC kind of guys, where they were like, yeah, let's throw some sumo wrestler up against some taekwondo master, and let's say who was the biggest badass. That's what cardiologists do. They're like, we have these kind of medicines. We have these P2Y12 inhibitors. Let's put them up head to head and see who's the best. And so the three main trials that we've looked at, there's been a ton of them, as Dr. Neff said. First one was CURE, which was looking at Plavix versus placebo. After that was 2000, 2001. 2007 was Triton Timmy 38, which looked at Plavix. So we're like, Plavix is great. Let's look at Plavix versus Effient. Okay, Effient won that head to head. And you have Plato, which is looking at, I believe, Plavix versus Brilinta, and Brilinta had a significant improvement in cardiovascular outcomes compared to Plavix. So now we have the two winner bracket winners, Brilinta and Effient, come together in this treatment study. And what they found was interesting, as Dr. Neff said. I look at this study, probably everyone listening to this is going to be too young to know who this is, but you look at like this baseball player named Brady Anderson. He was a guy who played ball in the 90s when I was growing up. And he was like the skinny left-handed hitter, outfielder, hit maybe 15 home runs. Best year was like 20 home runs. And in 1996, he hit 50. And you're like, what the hell, man? How did you go from being this little puny kid to now hitting 50 home runs? You're like, something is not making sense to me. It's kind of how this study is to a degree. If you look at the study comparing Plavix versus hot nothing, placebo, I give you placebo or I give you Plavix. Which one is better for cardiovascular outcomes? The relative risk reduction was not as good as Effient compared to Brilinta. Effient versus Brilinta showed improved outcomes more so than Plavix versus nothing, which makes almost zero sense because all the studies, they went into this thinking that Effient versus Brilinta was going to just wipe the floor with Effient. So it was a very unusual, significant outcome. And so now when you see findings that are not expected, you need to go back through the study and look at what are the differences, and were any of those differences sufficient enough to explain this profoundly unusual outcome or result. That's something Dr. Connell can speak to a little bit. You look at attention to treat versus per protocol, how are the numbers that you get manipulated? You can look at the as Dr. Neff mentioned, there were more dropouts or discontinuations of Brilinta versus Effient. Is that because Brilinta is twice a day? Is it because 85% of the people that they got this data from were just phone calls. There was no follow-up. There was no pill counts. There was no bottle counts. So is that actually real information? It was an open label design. It was not double blinded. So does that play any part in this? So I think we see some results that are like you're wrestling way above your weight class, Effiant. So what was done differently to make this result look that significant? There's changes in how you do Effiant, as we talked about. Effiant's always given after diet shot versus Brilinta is not. Effiant has indications only for people getting PCI, whereas Brilinta has been indicated for people with stable non-PCI CAD. So a lot of variations, and I think that's why with this study, you don't see guidelines changing dramatically, because there's enough question mark in this very clearly beneficial study for people to say, wait a second, let's make sure we have all of our ducks in a row before we just say Effiant's the winner.
So Christina Connell here. To the UFC comment, it was karate versus Brazilian Jiu-Jitsu. The Gracie videos on YouTube are phenomenal. Moving back into medical realm now. So like Dr. Conister said, how you design your study is going to greatly influence what you get on the outcome. And so the fact that they were looking for superiority, they should have done it in intention to treat the way they did, because if they had done it per protocol, like Dr. Neff said, you would have biased towards the Brilinta group. Because if you look at the dropout rate, Brilinta had a huge dropout rate, and people dropped out faster than they did with the Effiant rate. Again, why did they do that? We could discuss that all day long, but the reality is they did their trial design, at least in that part, correctly, because you want intention to treat when you're looking for superiority, because you want to see, hey, are people dropping out? Is there something wrong with your control group? Is there something wrong with your drug? Per protocol tells us what the perfect patient is going to do in the perfect situation, but we all know from the hospital and clinic that the perfect patient rarely exists. And so you want to know, how is this drug going to function in the real world? And that's kind of what you see here. Now, again, there are a lot of other questions, is how did Effiant come out on top here? Again, we could discuss multiple different points of the trial design, but the teaching point I want to make here is that it's really important to look at what were they looking for? Were they looking for non-inferiority? Were they looking for superiority? And then how did they go about that? Did they do intention to treat? Did they do per protocol? And do those things match up the way they should? Because you can get some significant biases if you design it wrong. So that's all I got.
Okay, well, I don't understand why Daniel was made out to be the big bad guy in all this, but what we found is that Brilinta is great, Effiant seems to be great, and we still don't have a guideline to tell us which one to use in those getting PCI. But I'm still Team Brilinta, just FYI.